Hello, good night, everyone. I am Sharice Arjun from San Fernando General Hospital Neurosurgery. Tonight, I'll be presenting on surgical approaches to the pineal region tumors. So I'll start off with a little bit of anatomy. The pineal gland is located in the diencephalic roof of the posterior extremity to the third ventricle between the habenula commissure and the posterior commissure, and it lies between the superior colliculi and the basal and it's basal to the splenium of the corpus callosum. So in terms of the boundaries, the superior boundary is the splenium of the corpus callosum, the hippocampal commissure, and the posterior aspect of the talar choroidae. Anterior boundary is the posterior aspect of the third ventricle, including the habenula and the posterior commissures, between which the pineal gland attaches, and the quadrigeminal plate. The inferior boundary is the cerebellum, mainly the vermis of it. Laterally, the pulvinar nucleus of the thalamus and the medial cerebral hemispheres, and posteriorly, the tentorial apex. In terms of the arterial supply, the posterior cerebral and superior cerebellar arteries the contribute to its arterial supply, and the lateral and medial posterior choroidal arteries, the latter of which primarily supplies the gland. In terms of the venous drainage, the great vein of Galen and its tributaries form a roof-like, dense venous network above the pineal body and the quadrigeminal plate. So in terms of the surgical anatomy, most of these tumors arise from or are attached to the undersurface of the velum interpositum. Tumors rarely extend above the velum, and the blood supply comes from within the velum, mainly from the medial posterior choroidal and the lateral posterior choroidal, with anastomosis to the pericallosal and quadrigeminal artery. Most of these tumors are centered at the pineal gland. Some extend to the foramen of Monro, and most of the intracerebral veins, Galen, Rosenthal, and the precentral cerebellar veins surround or cap the periphery of these tumors. Rarely, the intracerebral veins are ventral to the tumor, and highly vascular pineal tumors would include the pineoblastomas and the hemangioblastomas. In terms of the history of surgery and landmarks of pineal tumors, in 1910, Horsley first did the first attempt at resection of a tumor in the pineal region. In 1913, though, Krauss had the first successful surgery, and in 1921, Dandy would have come up with the parieto-occipital transcallosal approach. Van Magenen in 1931, the transcortical transventricular approach. Poppen in 1960, the occipital transtentorial approach, and Stein in 1971 popularized the infratentorial supracerebellar approach. So what are the indications to operate? So pineal region tumors, they account for only 0.5 to 1% of all intracranial neoplasms in adults. When they commonly present with Parinat syndrome, symptoms of obstructive hydrocephalus, cranial nerve palsies, and diabetes insipidus in children. So in terms of preoperative management, we all start with history and examination of these patients. And if the patient is an extremist with signs of obstructive hydrocephalus, they may require immediate CSF diversion procedures, such as a EVD or external ventricular drain, serum or CSF um, markers, such as for alpha fetoprotein, beta HCG, CEA, and acid phosphatase. And it is also important to be mindful. Some of these patients, lumbar punctures will be contraindicated because it could worsen cause worsening herniation syndrome. So in those cases, CSF could be obtained at the time of a diversion procedure. Total imaging of the central nervous system is recommended if there is suspicion for any drop metastases, in this case MRI brain plus whole spine with gadolinium, to look for leptomeningeal seeding. So the management of these patients are geared with these three things in mind. Does the patient have hydrocephalus? We have to do a tissue diagnosis and tumor control. So in terms of hydrocephalus, to address emergently, we can do diversion procedures as mentioned before, the external ventricular drain, ventriculoperitoneal shunts, or endoscopic third ventriculostomies plus or minus a biopsy, and in that case too, we would get a tissue diagnosis. Other ways to obtain tissue diagnosis would be by either a stereotactic biopsy versus an open surgery. And then tumor control, we would consider things such as radiotherapy and surgery. CSF cytology and radiographic imaging provide insight into the histological diagnosis, but they are not sufficiently sensitive to supplant a tissue diagnosis. Given the diverse pathology that can occur in the pineal region, a histological diagnosis is necessary to obtain management decisions. So if hydrocephalus is present, we do an endoscopic biopsy plus which would be an ETV. And if no hydrocephalus is or endoscopy is present, then we would have to resort to doing open or stereotactic biopsies. With regard to radiation, there was some controversy around it, where the concept was that if a pineal region tumor enhanced uniformly and had a classic appearance of a germinoma on an MRI, a test dose of 5 grays was given. And if the tumor would shrink, then the diagnosis of a germinoma was virtually certain and radiation therapy was continued without surgery. The only time that a tissue diagnosis is unnecessary is in the presence of a malignant germ cell markers where chemotherapy and radiation therapy should proceed without a biopsy, and tissue diagnosis can be achieved by either stereotaxis, endoscopic, or an open procedure, which we would delve in later on. This decision is influenced by clinical features of the patient, radiographic features of the tumor, the surgeon's degree of experience and expertise with these procedures. So in addressing hydrocephalus, this is one of the most common things, as I would have mentioned before, and it's present in almost all the cases. It must be addressed prior to tumor surgery. So in stable patients, complete resection is where complete resection is likely, temporary EVD at the time of surgery can be done. For symptomatic patients with raised intracranial pressure, we have options such as the ETV and biopsy, and the advantages to this is that it gradually reduces the ICP, it avoids peritoneal seeding, and it avoids shunt-related complications. And of course, a ventriculoperitoneal shunt is also an way to divert CSF as well. So starting off with stereotactic biopsies. Good candidates for stereotactic biopsies would include patients with known primary systemic tumors, multiple lesions, or medical conditions that can make open resection dangerous. The advantages is relative ease to perform and reduce complications when compared to open procedures, and the added advantage of stereotactic aspiration to drain cystic masses of the pineal region in the case of cysts and tumors. Stereotactic radiosurgery is also employed as definitive management for meningiomas, pineocytomas, and other vascular malformations of a suitable size. So the risks involve hemorrhage from several mechanisms, including bleeding in highly vascular tumors, damage to the deep venous system, and bleeding into the ventricle where the tissue turgor is insufficient to tamponade minor bleeding. Several larger series have validated the relative safety of stereotactic biopsies for these tumors despite their location. The risks of metastatic seeding along the biopsy tract after biopsy of a pineoblastoma. So, what are the indications for stereotactic biopsies? Again, I would reiterate invasive disseminated tumor at diagnosis, where the patient has multiple medical conditions or comorbidities, selected cases with very large tumors, neonates with large tumors, which can be highly malignant and associated with a poor prognosis, presentation suggestive of infectious or metastatic disease with diffuse systemic disease. And the target selection would be avidly enhancing tumor, preferably from the center and multiple sites. So MRI plus contrast is necessary to show the lesion adequately and to determine its relationship to the tentorium, the deep venous structures, the third ventricle, and the midbrain. Stereotactic procedures in competent adults and adolescents can be performed under local anesthesia supplemented with intravenous sedation. Low frontal entry point is employed for midline pineal lesions. Biopsy or aspiration is performed, and the entry point to the brain at the hairline or mid or high forehead level, where the instrument enters through the frontal horn of the lateral ventricle or just lateral to it, and it traverses the thalamus and occasionally the third ventricle and then enters the tumor. The goal is for the instrument to pass below the roof of the third ventricle and internal cerebral veins, usually displaced just superior to the tumor. And it allows for sampling of cerebrospinal fluid if desired. And the diagram here shows the trajectory of this biopsy. In the case of lateral pineal region tumors, it's better approach from the side via parietal trajectory, and the probe entrance is at the crest of a gyrus rather than a sulcus to avoid PL blood vessels that might lead to superficial brain hemorrhage, and several biopsies are desirable whenever possible. However, this is often prohibited by the small size of the tumors commonly encountered. Moving on to endoscopic biopsies. These endoscopic biopsies of the pineal tumors through the ventricle is an alternative method for securing a tissue diagnosis, and this approach is typically combined with the third ventriculostomy for CSF diversion. Even with flexible endoscopes, it is difficult to perform a biopsy simultaneously with a ventriculostomy because the trajectory required is different for each procedure, and some surgeons use a combined rigid and flexible endoscopic approach, while others have used the classic precoronal entry for the ETV and a second, more anterior entry for access to the posterior third ventricle and the pineal region. More recently, endoscopic surgeons has employed a rigid scope via an infratentorial supracerebellar trajectory to the pineal region. So for the infratonsorial supracerebellar endoscopic biopsy approach, the patient is placed in a semi-sitting position with slight neck flexion, and a 2.5 centimeter skin incision is placed at the inion, A 1.5 to 2 centimeter keyhole craniotomy centered just below the inion, inferior to the confluence of the transverse sinus and the superior sagittal sinus. In this case, mild hyperventilation, mannitol, and gravity causes the cerebellar tonsils to hang dependently and allows the opening of a corridor in the supracerebellar and infratentorial space, and a 0-degree scope endoscope is then guided atraumatically along this path with minimal dissection and occasional bipolar cauterization of a tentorial vein and no retraction of the cerebellar tissues to the posterior pineal region. In addition to sampling error, a major drawback to standard anterior endoscopic approaches is that the tumor is biopsied along its ventricular surface where there is no tissue turgor to tampen out the bleeding, and even minor bleeding within a CSF space can be difficult to manage at times, and a problem that is intensified by high vascular properties of many pineal tumors and the standard risks of endoscopy, such as phonoceal trauma, damage to the septal and thalamostriate veins at the foramen of Monro, can occur with manipulation of the endoscope. So now moving on into the open surgical approaches. The advantages I'll start with. The main one is of these open resection is the ability to obtain larger amounts of tissue and more extensive tissue sampling. This is important for pineal region lesions in general and germ cell tumors in particular because of the heterogeneity of the tumors and mixed cell populations are common. The tumor burden is reduced with an open procedure, and for the third of tumors that are benign, resection is usually complete and curative. Open surgery in patients with mild hydrocephalus whose tumors can be completely resected can negate the need for CSF diversion via VP shunts. So the approaches to the pineal regions are categorized as supratentorial approaches and infratentorial approaches. Under the supratentorial approaches, some would include the transcallosal interhemispheric approach, the occipital transtentorial approach, rarely used, but the use of a transcortical transventricular approach, and infratensorial, the approach is through a natural corridor created between the tensorium and the cerebellum. So the choice of approach again depends on the surgeon's experience and the comfort with the specific technique, as well as characteristics of the lesion itself. Large tumors that extend supratentorially or laterally to the trigone of the lateral ventricle benefit from supratentorial approaches. Supratentorial approaches afford greater exposure than infratentorial approaches do, but they have the disadvantage of forcing the surgeon to work around the convergence of the vein of Galen and the internal cerebral veins where they interfere with tumor removal. The location of most pineal tumors are infratentorially and in the midline, and it gives the infratentorial supracerebellar approach several natural advantages. It is the most effectively performed with the patient in a sitting position where gravity allows the cerebellum and the tumor to drop downward. The tumor can then be dissected more easily of the deep venous system and the velum interpositum, which is often the most technically difficult portion of the tumor dissection. Besides the obvious anatomical advantage of using a midline trajectory, the deep venous system lies dorsal to the mass, thus making it more avoidable through most of the tumor dissection, and the approach is less favorable if the tumor has a significant supratensorial or lateral extension, although with the appropriate extra long instruments, even tumors extending anteriorly into the third ventricle can be removed. So these would be the approaches that would be further discussed in this presentation. On the supratensorial approaches, the posterior interhemispheric transcallosal intravenous or paravenous approach, the posterior transcortical transventricular approach, the occipital interhemispheric transtensorial approach, and infratensorial, the approaches, the infratensorial supracerebellar transventricular approach. So surgery, the common approaches would be the infratensorial supracerebellar approach, and this is approaches to the center of the tumor. It minimizes the risk to the veins and injuring them. There's good exposure and minimal violation of normal tissue. The occipital transtensorial or transcallosal interhemispheric approach, used for tumors extending superiorly, extending laterally, and displaces the veins ventrally, larger tumors, and it allows for greater exposure. So how do we choose the approach? The approach is chosen based on the location of the tumor morphology, the displacement of the great veins, probable diagnosis on imaging, the angle of the tentorium and the posterior fossa size has to be considered as well, and last but not least, again, surgeon's preference. So starting with the posterior interhemispheric transcallosal intravenous or paravenous approach, this posterior transcallosal approach, it gains access to the roof and the medial part of the atrium of the lateral ventricles before entering the posterior third ventricle. This is done by splitting the splenium of the corpus callosum and is contraindicated for patients with a preoperative homonymous hemianopia contralateral to the dominant hemisphere due to the risk of alexia. Because the lateral ventricles extend laterally to this region, the lateral part of the atrium is not well visualized by this route. Preoperatively, as an anterior approach, in the anterior approaches, a MRV or A helps to guide the placement of the craniotomy by visualizing the dominant cortical draining vessels. So the patient is positioned in a park bench position with the parietal area of the operated side in the dependent position, and it allows the hemisphere to fall off from the falx, minimizing brain retraction. The craniotomy begins at the posterior edge of the postcentral gyrus, and it extends approximately 4 centimeters posteriorly. The craniotomy exposes the superior sagittal sinus, and it extends laterally to 4 centimeters, and the dura is reflected medially, and care is taken to maintain the large draining vessels. The parietal lobe is gently retracted approximately 2 centimeters away from the falx. Once the arachnoid adhesions are opened, the distal pericallosal arteries and the splenium are identified. Below the splenium, the internal cerebral veins join Gallen's vein, and the latter can be seen once the splenium is cut. The splenium is incised with a bipolar cautery, and this incision must be made lateral to the midline because of the atrium of the lateral ventricle deviates laterally, and access into the atrium is now achieved. So following access to the lateral ventricle, the choroidal dissection is performed medial to the lateral ventricular choroid through the tinea fornicis, separating the choroid from the body of the fornix, and the choroid plexus is either removed or reflected laterally. This minimizes contact with the posterior choroidal artery and the superficial thalamic veins. Once the choroid is reflected laterally, the velum interpositum, the intracerebral veins, and the medial posterior choroidal arteries are visualized, as we could see in the diagram. At this point, the internal cerebral veins are separated and the plane is developed between them. This is intravenous. Alternatively, the internal cerebral vein is dissected from the ipsilateral fornix to expose the third ventricle, and this is paravenous. There is no reported bridging veins between these vessels. Nevertheless, because they run so closely together, they require manipulation and intermittent compression to gain access to the third ventricle. The last layer is in this approach is to split the third ventricle choroid plexus, which must also be separated in the midline. Moving on to the posterior transcortical transventricular approach. So the patient is placed in a park bench position and a parietal craniotomy centered behind the post-central gyrus over the superior parietal lobule of the non-dominant hemisphere is performed. This will avoid the visual pathways traversing the parietal lobe and the speech areas at the junction of the parietal and temporal lobes. The lateral ventricle is accessed above the junction of the body and the atrium and above the body of the crus of the fornix. The choroid plexus will provide an orienting landmark and it forms a fringe attachment to the superior and posterior surface of the thalamus along the lateral margin of the body and crus of the fornix. The body and the crus of the fornix at this level fill the interval between the choroid plexus and the lower surface of the corpus callosum. This approach will expose the calca vis and the bulb of the corpus callosum in the medial wall, the pulvinar in the anterior wall, and the collateral trigone in the floor. The posterior part of the third ventricle is accessed via opening the choroidal fissure, opening along the crus fornix. So in C, the diagram C, we could see the atrium where the lateral wall and the roof are formed by the tapetum of the corpus callosum, and the floor is formed by the collateral trigone, which overlies the collateral sulcus, and the inferior part of the medial wall is formed by the calca vis. The prominence that overlies the deep end of the calcarean sulcus and the superior part of the medial wall is formed by the bulb of the corpus callosum, which overlies the forceps major. This approach can lead to interruption of the optic radiation, causing visual deficits, and leads to disturbances in the visuospatial function. In the dominant hemisphere, it may also lead to aphasia and agnosia. Gertzmann syndrome can result if the inferior parietal lobule of the dominant hemisphere is incised. So the indication for this approach would be tumors extending into the lateral ventricle. And the disadvantage of this approach would be a limited exposure, cortical incision required, which could lead to other deficits, and stereotactic guidance may be required. Moving on now to the third open approach, the occipital interhemispheric transtensorial approach. This approach is used for pineal and posterior third ventricular lesions with either supratensorial or infratensorial components. The patient can be placed in either the sitting or park bench position. In park bench, the operative side, usually the right, is placed lowermost, allowing the occipital lobe to fall away, thus reducing the need for retraction. And a U-shaped incision is made with its base inferiorly at the inion and across the midline. The occipital craniotomy exposes the posterior sagittal and the transverse sinuses. The dura is opened with its base on the sinuses, and minimal retraction on the occipital lobe is necessary with adequate CSF drainage and brain relaxation. There are rarely significant draining veins from the medial occipital lobe into the tentorium. And here we can appreciate the positioning. For a tumor in the posterior third ventricle, the tentorium may be divided lateral and parallel to the straight sinus from the free edge to near the transverse sinus. The transection of the tentorium proceeds in a posterior to anterior direction by first making an incision proximally and then proceeding in a line approximately 1 centimeter off the midline towards the tensorial edge. The tensorium is well vascularized, and hemostasis may require bipolar cautery and clips. The thick arachnoid should be separated at the edge of the sensorium to avoid undue bleeding of the vessels, and the arachnoid over the ambient and quadrigeminal cisterns is open but sharp dissection, and the ipsilateral basal vein, medial posterior choroidal, and posterior cerebral arteries and the thalamus are lateral to the tumor. If necessary, the precentral cerebellar vein should be sacrificed to increase the working space. The tumor resection can proceed between the internal cerebral veins and horizontal basal vein. The falx can be cut approximately 1 centimeter anterior to the insertion of the vein of Galen into the sinus after coagulating or clipping the inferior sagittal sinus. Retraction on the falx allows further exposure, and the splenium does not have to be cut, but can be gently retracted upward to allow extra exposure. So this is the commonest supratensorial approach that was described. The indications, to reiterate, would be for predominantly supratensorial lesions, where there's corpus callosum extension, lateral extension into the cerebral hemisphere, thalamic extension, predominantly third ventricular masses. The advantages of using this procedure and approach would be for extensive tumor view. Managing bleeding is easier. working distance is smaller, and access to the pineal, third ventricle, midbrain, and superior vermis. The disadvantage would be the view can be obstructed by the galenic venous system and restricted view of the opposite side. So the complications of the supratensorial approaches would include hemiparesis from brain retraction and sacrificing of bridging veins, sensory stereognostic deficits such as parietal lobe retraction injury, visual field deficits from occipital lobe retraction injury, disconnection syndrome from corpus callosum section, memory deficits from phonoceal injuries, bleeding in the bleeds within the residual tumor, and venous infarction. So now moving on to the infratensorial supracerebellar transventricular approach. This approach is well suited for midline tumors in the pineal region and avoids retraction or manipulation of the cerebral hemispheres. The approach is not optimally suited if the tumor infiltrates laterally or superiorly above the tentorium, and the sitting position is optimal for brain relaxation. The cerebellum falls away while the venous drainage is optimized. If this position is chosen, the patient is susceptible to air embolus, thus a central line carbon dioxide monitor, PEEP, and compression stockings are advised. This is how the position can be done where sitting is preferred, can also be done in a concord position. Um, with large ventricles, less than 3 years to the three-quarter prone. The surgical table must be able to go low and the head flexed to keep the tentorium parallel to the floor and the patient tilted forward slightly. With regard to exposure with the incision, it extends from the inion to C4. The spinous process of C2 is exposed. The burr hole is done above the torcular, lateral aspect of the transverse sinus. The craniotomy is above the transverse sinus and the torcular. Bone edges waxed. If dura is tense, release CSF by a ventricular tap. Dural incision is curved between lateral most aspect of the transverse sinus, and the dura is retracted to avoid excess retraction or sinus occlusion. The surgical technique: cauterize and divise the adhesions and the veins between the cerebellum and the tentorium. Retract the vermis posterior inferiorly. Open the arachnoid over the tumor, which is opaque or white. The midline precentral cerebellar vein is divided. Small branches of the choroidal and the SC over the tumor is divided. The trajectory of the dissection changed towards the tumor, and internal debulking of the tumor is done. The lateral walls dissected, the vessels on it are the choroidal and may be sacrificed. Dissection of the inferior tumor from the brainstem, most dangerous part of the procedure. The assistant retracts the capsule upward, and the final dissection is superior along the velum interpositum, great veins, where the great veins are at risk. So this shows us a little bit of the view that we would be looking for to access the tumor. With this approach, mortality is 3 to 4%, and the complications would include transient ocular dysfunction, ataxia, cognitive impairment, akinetic mutism, and brainstem handling, and the bleed in incompletely resected tumor as well. So the advantage of this approach is that gravity aids the drainage of blood and CSF. It also aids cerebellar retraction. It's in the midline, so the orientation is easy, no neural structures and roots. And the disadvantage is the risk for air embolism, surgeon's fatigue, difficult and very young and very old patients, quadriplegia from excessive flexion in the elderly, and hypotension. So other adjuncts um, to managing these patients, we would consider radiotherapy, most likely in the cases where, primary lesions are germanomas, as we have discussed it before, and it could be used as adjuvant therapy as well in the cases of the pineal blastomas and all malignant germ cell or pineal cell neoplasms. Gamma knife radiosurgery is for when it is histologically confirmed with maximum experience with the pinealocytomas, is used as an adjuvant therapy, possibly primary therapy for the pinealocytomas, and the indications are still evolving. The current possible indications would be for pineal parenchymal tumors, germanomas, non-germanomatous germ cell tumors, and astrocytomas. Adjuvant therapy here in the form of chemotherapy, the indications would be in non-germanomatous malignant germ cell tumors, germanomas with syncytiotrophoblastic giant cells, recurrent or disseminated pineal cell tumors, cisplatin or carboplatin plus etoposide, and others would include vincristine, lomustine, and cyclophosphamide. So these two tables was just a summary to summarize all the different approaches and highlight the main advantages, disadvantages, and indications based on the location of the tumors. So this could be read in your own time. This brings me to the end of this presentation. Thank you very much.